We have two speakers to start us off. Going to be co-presenting is Karen Floriano-Heimerl is a speech pathologist who treats Parkinson's disease and other neurological disorders. Karen certified in LSVT Loud and Speak Out. She helps to coordinate the Aurora BayCare Medical Center Parkinson's Support Group and offers a quarterly, hopefully soon to be monthly, group voice class called Raise Your Voice. This is a group for people with Parkinson's who have completed speech therapy for voice speech and need that ongoing exercise boost. Along with her will be Adie Minor. Adie is a speech language pathologist who treats Parkinson's and other neurological disorders. Adie is certified in LSVT Loud and has much experience helping individuals manage acute chronic dysphagia. She's looking forward to becoming a co-facilitator of the Raise Your Voice group voice class for people with Parkinson's. Welcome, Karen and Adie.
Good morning, everybody. Just want to make sure people can hear me. Justin, can you give me kind of a heads up?
Yep, you're good to go.
Okay. So thank you to the Wisconsin Parkinson Association and all of our sponsors today so that we could put on this program for everybody. And thanks for joining us. My coworker Adie and I have information that we're going to share with you regarding ways that we are able to help you with voice and swallowing changes associated with Parkinson's disease. So just a couple of thoughts that I want people to ponder as you listen to us talk this morning. The way we communicate with others and ourselves ultimately determines the quality of our lives. Next, the gathering place, good food, good friends, good company. Next, communication is one of the most important skills you require for a successful life. And lastly, good friends, good food, good times. So just keep thinking, especially with the holidays coming up, whether you're going to be in person with family and friends or virtual, the importance of communication as well as eating and often how those go together. All right, so bottom line, a couple of things to cover just related to neurology. So we all know that we have neurons that produce a chemical called dopamine, and with Parkinson's, these neurons die or become impaired. 80% of the dopamine producing cells are actually lost by the time the motor symptoms of Parkinson's appear. Dopamine is a neurotransmitter that transmits impulses from one neuron to the next for the planning and controlling of automatic muscle movements. Without enough dopamine, automatic movements are disrupted. It's also important to note that dopamine is responsible for our motivation and our drive. So these things can also be impacted for people with Parkinson's. Sorry, I'm having a little issue with my screen. So let's talk just for a moment about what some automatic movements are. These can include things like walking, swallowing, blinking, swinging your arms when you're walking, getting out of a chair, or picking up a fork. And one that, of course, we want you to focus on is the production of speech. So let's talk for a minute about a dilemma that we have with this. They say that 90% of individuals with Parkinson's are likely to develop speech disorders. Some early signs of a speech disorder would include reduced volume, vocal hoarseness, frequent throat clearing, trailing off at the end of sentences, and inconsistent production of the voice. A concern with speech disorders is that communication issues are often less apparent because they don't really result in any physical differences that you would see with changes or issues in walking or balance. Communication issues tend to develop gradually they're often overlooked and often compensated for subconsciously. Unlike somebody who might be falling and having physical changes, there are no bruises or bandages after a communication breakdown, and the moment just comes and goes. So we do have some good news after all of those things that are a little bit more negative, and that is that humans have two motor systems. We have something called the extrapyramidal and the pyramidal motor system. I'm going to talk just for a few minutes about each of these, and the information I'm sharing is on the upcoming slides, but I'm going to keep it on this slide as I give a description of each of these. So the extrapyramidal system is the system that's responsible for automatic movements, and this system is very dependent on dopamine. They compare this to a system of like country roads. So country roads, they're often shorter roads with lots of stops. And you can see with all the different green lines here, how they're short, they're all over the place. And what happens in the brain is they travel from the outer portion of the brain, the cortex, into the brain stem. And they do communicate with the substantia nigra. So they all directly get to that area because they rely on dopamine, which is produced there. So this enables the smooth, coordinated movements that need to happen automatically for us without conscious effort. So when people with Parkinson's who have a loss of that dopamine, when they go to make those automatic movements, they often become disrupted. Then on the other side, we have the pyramidal motor system, which is more responsible for our intentional movements. And this is more like the expressway. So you can see these with the blue lines compared to the green in the extrapyramidal system. There's kind of a more direct shot from the cortex to the brainstem, and they actually bypass the substantia nigra. So they do not depend on that dopamine. This system tends to work well for people with Parkinson's. So the more intentional and deliberate movements should be preserved. We can activate this system when we consciously and purposefully produce a movement, such as trying to speak clearly or swallow hard and fast. So now let's bring it back to speech. Speech, as I had mentioned, is very automatic, and all systems work together simultaneously and automatically. These systems include the way that we breathe, our voicing, the way we articulate the sounds, and also prosody. Prosody has to do with our rate of speech, the way we stress our words, the rhythm of our speech. With Parkinson's, the coordination of these systems might become inefficient, and people with Parkinson's need to learn to be more intentional when they speak. So we have some more good news. And that good news is that many people with Parkinson's have the capability to regain and maintain their speaking abilities if they receive intensive individual therapy. And notice the word regularly is bolded and underlined because it's so important to continue to have that regular exercise of the muscles that are used for speaking, just like many of you probably regularly exercise the muscles in your arms and legs and core. But we also talked before about people with Parkinson's struggling with motivation. And it does help if we can have a simple, structured, and intensive program with regular follow-ups and ongoing encouragement to help them make these changes in their speech. So what do we do? I know a lot of people probably know about Lee Silverman voice therapy, LOUD. Some people just call it LOUD. I'm going to talk a little bit more about a newer program called Speak Out that is developed by the Parkinson Voice Project. And it has a single focus on intent. We've talked about the intentional motor system. We've talked about the need to be intentional and deliberate with movements to help make them more effective. So Speak Out teaches people with Parkinson's how to convert their speech from an automatic function to a more intentional act. So we're relying less on that system that uses dopamine and more on the system that bypasses that need for dopamine. That's the pyramidal motor system. Some examples in life of when we might use intent would be thinking back to your very first job interview, driving down the freeway while it's raining or snowing, exercising, maybe putting on your makeup, shaving. And for me, giving this presentation, I'm using more intent in the way that I speak so that hopefully everybody can hear and understand me easily. So the process you would go through if you wanted to go to therapy for Speak Out or really even for LSVT Loud is we first need a referral from your physician. Then you would seek out a therapist who is certified in LSVT Loud or Speak Out. And there are a few different candidacy criteria points that we like to look at. A person should be able to tolerate at least 45 minutes of therapy, follow simple commands, and show improvement in 2 or more of the following when using intent. This could involve better breath support. Of course, we're hoping for increased volume, better vocal quality, clearer articulation, and even improvements in the intonation of speech. We also want to know that a person can complete daily home exercises by themselves, or that they have somebody available who can help them to complete these, because this is an essential part of the therapy process. Speak Out has a nice informational video for people to watch on their website before starting therapy. That just gives a nice introduction of the program. And they also have a workbook that can be ordered for free. They are a nonprofit organization and they provide therapy for free at their home base in Texas. They follow a pay it forward philosophy. So they really operate off of donations. And once these things are in place, then you start the therapy process. So Speak Out involves, as we mentioned before, focusing on speaking with intent at all times. It is a 3-day-a-week or 4-week program, which is 12 sessions. And there is some flexibility after week 2 if we have an individual who's maybe really just doing fantastically with their voice and their homework. So there's a little bit of flexibility there. Sessions are 45 to 60 minutes, and they incorporate 6 different components. We always do these components in each session. We have a vocal warm-up, the ah, where we're sustaining a vowel. We do pitch glides, number sequences, reading out loud, and we also have cognitive exercise embedded in the session. Daily home practice, as I mentioned, is an essential part of Speak Out and LSVT Loud, and it is a huge part of how much progress a patient will make. The patient uses their workbook for this, which includes those same 6 components. After somebody completes Speak Out, we ask that that daily home exercise continues. Research shows that patients who continue to do that do well and do better than those who kind of fall off that bandwagon of that daily home program. We like to see patients back for some follow-up sessions at 6 weeks, 3 months, and 6 months, depending on how they're doing. And you should also check within your community if you have any opportunity to attend a voice class, such as the one that we have here, we call Raise Your Voice. It was being offered monthly, actually. And then, of course, we have not been able to meet in person, and now we're looking at starting our virtual class, hopefully in December. There are other classes that do incorporate vocal exercise, such as at Aurora BayCare, we have our mobile and fit exercise class that is virtual 2 days a week now, and I know that they incorporate some voice exercise. And Rock Steady Boxing is also in our area, and that involves some voice exercise too. I have a short video I'd like to show you that just highlights a woman, Melissa, before and after Speak Out Therapy. So I want you to pay attention, especially to her volume, but even her posture and her articulation.
Tell me your full name.
Melissa Ann Hildebrand,
And when were you diagnosed with Parkinson's?
September 4th, 2019.
Have you noticed a change in your voice or speech?
Yes, when I get excited or I'm nervous.
And what have you noticed?
I'll start slurring my speech and or it gets softer. More so of the first of being slurred.
Mm-hmm.
Or I never had a problem speaking to people before or stuttering.
Tell me your full name.
Melissa Ann Hildebrand.
And when were you diagnosed with Parkinson's?
September 4th, 2019.
Since you have completed the Speak Out program today, have you noticed a change in your voice or speech?
The change I've noticed is that I'm not having to repeat myself.
What have other people said to you about your voice?
My best friend said, I can hear you better. I can understand what you're saying. It's easier to carry a conversation.
Any other comments about your voice?
Keep it up. Keep up the good work.
When you want people to hear and understand you, what do you need to do?
When I want to be heard and understood, I think to speak of intent, focus, concentrate, and be purposeful.
And what do you like most about this new voice?
I feel like myself again.
Okay, so kind of wrapping up my part of the presentation, I want you to take away from this to choose to focus, to concentrate, be purposeful, be mindful. Any of those things that make you think about speaking with intent and deliberation or with gusto. And you can also think about walking like this and swallowing like this. We want to use that pyramidal motor system more instead of the extrapyramidal motor system. Just a couple of references here, and these are both great websites that you can go and find a ton of information. And a segue to my colleague, Adie. Did you know that working on your speech can have a positive impact on your swallowing as well?
Good morning. As Karen said, working on your speech can have an impact on your swallowing as well. So let's take a little look at swallowing. There are 4 stages of swallowing: oral preparatory phase, oral phase, pharyngeal phase, and esophageal phase. The oral preparatory phase is the anticipation of eating and drinking. It's bringing food and liquid to the mouth. It's your mouth preparing the salivary preparation. It's getting ready to eat. I'm going to click to the next slide to give a picture here to kind of show you where and what's happening during these phases. First, I'll give you a little anatomy so you know what we're talking about here. Here are the lips. Here's the tongue. This is the uvula, or that hanging ball in the back of your throat. Here's the esophagus that opens to send food down to the stomach. Here is the trachea, goes down to the lungs. At the top of the trachea, you have your vocal folds right here. They close when you swallow. And here is your epiglottis. Your Adam's apple goes up and out when you swallow, and that flips your epiglottis down to protect the airway. So the oral phase is contained in the mouth here. During the oral phase, you're chewing your food, you're collecting it into a nice ball or bolus. You're sealing that bolus between the tongue and the roof of the mouth, and then you're moving it backwards towards the pharynx here, the throat. That's where the pharyngeal phase starts, right in through here. And as I kind of alluded to, your Adam's apple comes up and out, flips over your epiglottis to protect your airway, the vocal folds close, and everything should pass down into the esophagus, which then starts the esophageal phase. Through that process, we have a mixture of automatic and intentional pieces. Okay, we're going to see if we can get a video up here of a normal swallow. Okay, again, just kind of give you some landmarks here. That's the spine. The dark is what the patient is eating and drinking. Up here is the mouth, the teeth, and the dark is going down into the esophagus, avoiding the airway or the trachea here. You can see the individual is pretty efficient in chewing, moving that bolus back, and then swallowing it down into the esophagus. That's just a little different view. Nothing in the airway, and there's really no residue or anything left in the throat after this individual swallows. Yeah. So pretty normal swallow there. So let's talk about what dysphagia is. Dysphagia is defined as difficulty with eating and drinking. It can happen at any stage of the swallow.
In this video fluoroscopy, in a lateral view,
Oops.
we can see
Bet you can hear that. I gotta stop.
anteriorly.
There we go. Sorry about that. Okay, there can be multiple causes for dysphagia: aging, treatment, surgery, radiation, medication side effects, but also disease such as Parkinson's disease. In fact, dysphagia can affect upwards of 90% of people with Parkinson's disease. It can happen or present itself at any stage of Parkinson's disease, and the changes are usually gradual. What's responsible for these changes, these swallowing changes in Parkinson's disease? It's really multifactorial. Multiple systems impact swallowing. So changes in those systems impact swallowing function, such as bradykinesia, the slowness in movement, tremor. Tremor can affect many stages of the swallow, even getting the food to the mouth to be able to drink or eat. Hypokinesia, rigidity, and sensory impairments. Just not having as keen of sensory information can affect your swallowing. The respiratory system is impacted, and there's often an impairment of cough or dyspepsia. That all impacts swallowing and airway protection in the act of swallowing. So what are some symptoms of dysphagia? There's many symptoms. The ones I listed here are maybe a little bit more common towards people with Parkinson's disease. In the oral preparatory phase, the slowness in eating, difficulty getting food or liquid to the mouth, drooling, repetitive pumping of the tongue, oral residue or things left in the mouth after you've swallowed, piecemeal deglutition, which means that ball or bolus of food that you formed in the mouth is swallowed down in 2 or 3 swallows. It's kind of broken and not just one nice formed ball. Residual in the throat after swallowing, difficulty coordinating breathing and swallowing. It's kind of interesting when you swallow. The typical breathing pattern is you're chewing, getting ready to swallow, you stop breathing while you swallow as your airway is being protected. And you usually do that in the middle of an exhalation. You finish swallowing and then you resume your exhalation and begin breathing again. But we can be uncoordinated with that, which can affect swallowing. The epiglottis, which protects the airway, may have reduced range of motion, and or you could end up with aspiration, which is food or liquids that end up in the airway. And then the esophagus is some difficulties with the esophageal phase include spasm, contractions, hypomotility. And just kind of an interesting little fact when we're talking about these phases of swallowing, people with Parkinson's disease have been found to swallow spontaneously at a lesser frequency than individuals without Parkinson's disease. The numbers stated here are 48 times per hour for someone who may have Parkinson's disease compared to someone who does not, who may be swallowing about 71 times per hour. It's quite often. You don't really stop and think about that. But swallowing 48 or 71 times per hour is frequent. Okay, let's see if we can get a video up here of what a swallow with someone with dysphagia looks like. I don't know the etiology of these swallowing difficulties, but it nonetheless demonstrates some difficulties. Again, the black, the dark is what this individual is eating and drinking. You can see that the liquid is spilling into the pharynx or the throat before a nice ball has been formed. You can see as the bolus is passing, this individual is trying to swallow, and it is not fluidly moving throughout the throat. Let's see if I can catch it here. But ultimately right there, liquid entered into the airway, passed below the vocal folds and towards the lungs. That would be considered aspiration. Just a very inefficient, it's not efficient. There and a lot of work to get that food and liquid down from the mouth down to the stomach. So dysphagia can really impact more than just the swallow. It impacts quality of life. As Karen started out the presentation, she indicated, thinking about the upcoming holidays, that food often accompanies social interactions, family interactions, interactions with friends. So not being able to eat and drink certainly can have an impact on some of those activities we do for enjoyment. It can also be a factor of malnutrition, failure to thrive, or weight loss. It can impact dehydration, and it ultimately can cause aspiration pneumonia, which is the #1 cause of death of people with Parkinson's disease. So it's something we want to certainly keep an eye on and help manage. It's always good to stop and think, kind of assess your swallow. Are you having any difficulties? Here are some things that you may ask yourself to determine if you are or are not. Things like, are you avoiding eating or drinking? Are you embarrassed to eat with others? Are you choking, drooling, coughing when eating? Having trouble taking pills? Experiencing loss of appetite? Trouble moving food back in your mouth? Managing unexpected weight loss? Sensation of food caught in your throat? Taking longer than normal to eat. And really stopping to think about these things, because people with Parkinson's disease have difficulty with sensory input. Sometimes they don't notice these difficulties as early, or family or friends may notice sooner. So just take time and kind of consciously, mindfully think about these things. If you are noticing difficulty, it's time for a swallow evaluation. And as Karen said before, in regards to voice therapy, you need to discuss this with your physician and ask for a referral for a swallow evaluation. And here's some good news. We can manage dysphagia. So let's talk about that a little bit. From a therapy perspective, we can manage things from a compensatory strategy approach and a restorative strategy approach. Compensatory strategies include things like diet modification, feeding strategies, use of postural strategies, and sometimes needing alternate methods of nutrition and hydration. Restorative strategies are exercises to help improve swallowing function. And interestingly, I heard a statistic that only 3 to 4% of people with Parkinson's disease actually end up having speech therapy for voice or swallowing. It's sort of a low percentage considering speech difficulties and swallowing difficulties can happen at such a high frequency. Why that is, I'm not sure, but kind of be aware of these things, be thinking about these, and be discussing treatment management with your physician. Because if you're a candidate, therapy's good. All right, a little bit more detail about some of these compensatory strategies. Diet modification can be thickening of liquids, or it can be modifying food textures. Thickening of liquids, we have thin liquids, nectar thick, and honey thick liquids. They get progressively thicker. And regarding texture modification, there's what's called dysphagia diets, and they break things down into 4 different levels very quickly. 1 is everything's pureed. 2 is cut up, chopped up, ground food, kind of fork mashable. 3 is soft and tender, and then 4 is back to any texture. Diet modification is often used with feeding strategies. Feeding strategies include modifying the environment, maybe reducing distractions, figuring out if a time of day is better for intake. There's also rate and volume strategies, small bites, small sips. Maybe you need a small utensil or a different type of utensil. And eating with mindful purpose and intent can fall under this feeding strategy, under feeding strategies as well. Kind of relying on the intentional pathway to improve your eating. Postural strategies, we also use those in conjunction with diet modification and feeding strategies. They may be things as sitting upright, using a chin tuck, like that, a head turn. But all of these should be done under the guidance of a trained professional, because what works for one person may not work for another. Such as a chin tuck, someone may benefit from a chin tuck, where someone else, a chin tuck might cause aspiration. But hopefully with the use of all these strategies, we can improve the safety of swallowing, improve airway protection. We also, in speech therapy, can help with other compensatory strategies for other things outside of the act of eating. Drooling would be one of them. Here are just a couple strategies that can be helpful in regarding drooling management. Swallowing more often. As I mentioned before, people with Parkinson's disease swallow at a lesser frequency across the day than people without. That allows saliva to build up. So just consciously and mindfully thinking about swallowing more often may be helpful. Drinking more water. People sometimes tell me this is counterintuitive. They feel like they've got a lot of saliva, so why would they need more water? But actually, water will force you to swallow, help you manage some of those secretions. And the secretions don't equate adequate hydration. So if you're avoiding drinking water, you increase your risk of dehydration. So keep drinking, stay hydrated. Sometimes people use a little spritzer bottle with fresh lemon juice and water, just kind of spritz in the mouth. What that's doing is triggering another swallow. Same principle behind sugar-free candy or gum. Having that in the mouth is hopefully going to help cue you to swallow more frequently, thus manage excess secretions and hopefully avoid drooling. Occasionally, diet modification, feeding strategies, postural strategies do not reduce the risk of aspiration, or despite those things, people still have airway protection issues and maybe aspirating. If that's the case, then alternate methods of nutrition and hydration should be considered. There are various types of nutrition and alternate methods of nutrition and hydration. This is a nasogastric tube. It goes through the nose, down to the stomach. That's usually a more acute, short-term type feeding tube, where the PEG, which goes into the stomach, and the JPEG, which goes into the intestines, maybe a little bit more chronic or long-term feeding tube. The use of a feeding tube for nutrition and hydration is a very personal decision. People have opinions on it, very personal opinions on the use of these methods for nutrition and hydration. I just encourage everybody, people with Parkinson's disease, people without Parkinson's disease, to talk to their family and share their opinions on this. So in case you ever end up in the situation where you have to consider one of these, or family is helping you consider one of these, you've already discussed and have kind of a foundation or a framework of where your opinions might stand. And then there's some restorative treatment. This includes exercises, oral pharyngeal strengthening exercises, meaning if applicable, we can strengthen lips, tongue, throat. We have various tools and exercises to help us do so. LSVT and Speak Out, both voice programs that can help swallowing function. We're using the same muscle systems for speaking and swallowing. We use some of the same systems, such as the respiratory system, for speaking and swallowing. So the overlap of therapy in the voice world can thus help dysphagia as well. And then various expiratory strengthening, cough training, improvement in the respiratory system to hopefully improve airway protection. It's kind of all bundled together in dysphagia therapy. Just as Kieran said though, since motivation can be challenging, it's good to get into therapy, to determine what exercises, what feeding strategies, what postural strategies are beneficial, kind of developing a individualized plan that's simple and can be routine, and then ongoing therapy to help carry that out consistently to improve, strengthen, improve coordination of breathing and swallowing. Another piece with dysphagia therapy is the education, and sometimes we just need patient education, caregiver education, family member education on how do I prepare textures to desired or beneficial consistencies, presentations to avoid coughing, choking. How do I cue for postural strategies? What kind of utensils do I need? So therapy can also take that, head down that path as well, just some kind of education that's specific and individualized to carry over at home as well. And then there's always new research coming out. So we try to keep up on that and keep it in our therapeutic tool bag as well.
Hi, Adie. It's Jeremy from the Parkinson Association. How are you?
Good.
Good. I'm going to jump in and do the Q&A right now. I know you have a couple slides left, but we're going to try and keep everybody on schedule for the other speakers.
Perfect. That's fine.
So if you want to stop screen sharing, because right now you're really tiny on everybody's screen, so if you can stop that, we'll be side by side and we can do just a handful of questions. First of all, I'll say you guys covered everything so well that there have been no questions submitted in the side chat. But I have a few questions I can ask you. Hi, Karen.
Hi.
Oh, I see.
There we go.
Okay.
So the couple questions we do have that were submitted ahead of time that hopefully will go fairly quickly for you. The first one is one I think we all are asking. With COVID right now, for speech therapy, is that something we can do virtually? Are you taking appointments? How are you doing that so people can continue to receive speech therapy as needed?
Yeah, we are offering virtual services. Sometimes we have to modify how our typical in-person therapy session may look, but still following the research and the protocols. But yeah, virtual is available.
Okay. Now,
and in person, still in person is available too.
Perfect. That was my big question. The other one, I forget, I took notes and I forgot who said this, but one of you said only 3% of people with Parkinson's disease actually seek out help for speech or swallowing issues. Do you have any theories as to why that is? Is that an insurance issue, that insurance doesn't cover it? They're afraid to ask. They don't know it's a Parkinson's thing. What kind of theories do you two have as to why that's such a small number?
I'll give my thoughts and Karen can jump in here too, but I think you hit the nail on the head. It's multiple reasons. I think symptoms are sometimes underreported. I don't always know, like Karen was saying, in regards to voicing, it doesn't always end up in a physical impairment. So maybe not always being discussed that, hey, your voice can be improved. Therapy may help that. Dysphagia symptoms may be mild and not as impactful early on, even though treatment may help early on, even for those mild pieces. Karen, other thoughts?
Yeah, I think I agree with everything Adie said, and I think it's a multitude of different factors. I also think that just in general in the medical world, not everybody knows what speech therapy encompasses, and that we are able to help people with these various issues, including voice and swallowing. So I think that's part of it as well.
Yes. And I think that's really a good point, Karen. When I've done these programs before, a lot of people, when they think speech therapy, they think voice. They don't always realize that swallowing is part of the whole therapy. So I think that's really important that you mentioned that. The last one I have, we've hit on it a couple times now in the questions, but you also talked about it earlier. We know a lot of people with Parkinson's, quiet voice or hypophonia becomes an issue and can impact socialization. Can you touch a little bit on what you see within the people you serve as to how that quiet voice, and then once they go through the therapy, how that changes their confidence, but also their ability to interact and socialize with others?
I'll take that one. I think that, well, you can kind of see in the video that I showed too, just the confidence, I think, is a big piece, that the person gains some confidence in the fact that they're able to say what they want to say. They feel like they can be heard. I think there's some emotional benefit to that. And we do use a tool in therapy it's called a patient-reported outcome measure. And it's called the Voice Handicap Index. So we have patients fill that out before and at the end of therapy. And it's always interesting to see the positive shift in the way that they perceive their ability to communicate.
And I think this year, I can just think of an example of this year, there's been, maybe we haven't been out and about as much, but there's been a lot going on that people have opinions on, and want to have discussions with family and friends and share their opinions, and just kind of gaining that confidence, having a little stronger voice. They've been able to engage in these conversations and make their opinions known.
Thank you both for sharing. I think that's a great point, Adie, is having your voice to be able to share your thoughts, your opinions. And I think it also dictates your ability for your Parkinson's care. If you have your voice, you can make sure you're heard, whether it's your therapist, your doctor, or your family, so they know what's going on. So thank you both for joining us in your presentation.